This lesson is about what we actually do in our office. It's about treatment. Earlier, we've talked a lot about philosophy, and we've talked about what behaviors are expected from patients. If you've had the opportunity to view our earlier videos, you already know some of this. So we're going to focus on what's most important and try to make it as straightforward and meaningful to you as possible. To tell this lesson, we have to go back to the beginning of our practice, some 40 years ago. Back then, in 1975, we practiced exclusively as specialists, helping patients with their gums. Our type of practice was known as conservative periodontics, and nearly all of our patients were referred to us by other dentists. As the years went by, more and more patients were coming into our practice directly, either by word of mouth or as friends or family members of our other patients. We found that we no longer had an exclusive practice. Most of these patients were coming to us for their primary dental care, and there were a lot of them. Today, we take care of more patients in this primary capacity than we do as periodontal referrals from other dentists. These are special patients who come to us because they already know. They know and want the most thorough maintenance that they can find. You see, the ideas and methods of conservative periodontics are the exact same ideas and methods for the best possible preventive care, preventing cavities, gum disease, tooth loss, and costly dental repairs. These are happy patients. For this lesson, we'll take some of those old school conservative periodontics ideas and methods, especially as taught by the late great Professor Sigurd Ramfjord of University of Michigan. You will see how we effectively modified them for the highest level of contemporary dental care. The scientific foundation of our practice was developed by Professor Sigurd Ramfjord, who lived from 1911 to 1997. He was a teacher, a dentist, and a scientist, the author of the Michigan Concept, which states, "In general terms, we are philosophically committed to a search for methods of prevention and treatment in which maximum benefits can be gained by minimum patient discomfort, as well as expenditure of time and money." We follow this philosophy. Maximum benefits with minimal discomfort, time, and cost for patients. This is a matter of attitude, the proper doctor-patient relationship. It's not a business deal or a sales pitch using your position to sell dental treatment to patients. And it really predates the Hippocratic Oath. It goes back at least to the Golden Rule from Confucius, 3,000 years BCE. This issue of human behavior, how individuals behave toward one another, is not only fundamental to the relationship, but is essential to our very civilization itself. If we do not pay enough attention to civilized behavior, human beings will revert back to primitive behaviors. Back to Ramfjord. Our search is for simple procedures, for minimal removal of the patient's hard and soft tissues, as well as minimal insertion of prosthetic appliances. In our practice, simple is good. We found a defined therapeutic endpoint that's repeatable and cost-effective. We focus on a clean, smooth root surface. It means no decay, it means no gum disease. Minimal means conserving the natural tissues. Back to Ramfjord. However, beyond all, we are committed to doing everything within our power to maintain the natural dentition in health and comfortable function throughout the lifetime of the individual. Well, there it is, the perfect or ideal outcome, what the entire goal of the practitioner and for every patient is all about, to maintain the natural dentition in health and comfortable function throughout the lifetime of the individual. Again, listen to what Ramford says. The aim of periodontal therapy is to make the tooth biologically acceptable to the surrounding periodontal tissues. Well, look at that. Make the tooth acceptable. Focus on the tooth and leave the gums alone. Ramford says, since there is no one-time cure for most periodontal diseases, long-term favorable results are determined by mutual cooperation between patients and professional personnel that goes beyond mere technical skill. Listen to that. No one-time cure. Mutual cooperation that goes beyond technical skill. It's a treatment relationship between patient and practitioner that matters. Both of these happen during our maintenance appointment. We teach patients about the soft stuff, the daily hygiene and the diet. We ask them to come in as clean as possible, and then we remove all the soft and hard deposits. And we spot and treat problems as early as possible. This takes time. Our maintenance visits are usually an hour and a quarter, sometimes more, maybe less. And it takes skill. It takes paying attention and understanding the biology of teeth. And it takes commitment. You have to have a genuine care for the outcome. Ramford further says that the average clinician is usually far too pessimistic regarding the prognosis for teeth with periodontal disease. It also appears that the potential for healing and maintenance of health and function of teeth with very deep periodontal pockets is much better than previously assumed. You see, scientific studies show that weakened teeth should not be extracted. Way too many teeth are being extracted. Not in our practice. Even very weak teeth can be returned to good health and function as long as we can produce a clean root for the gum to live against. Ramford continues, although many aspects of periodontal inflammation appear to be self-destructive, the inflammatory process is protective in an attempt to contain the injurious agents, and the inflamed tissues do not have to be surgically removed for improved healing. In our practice, we take advantage of these ideas. Inflammation, especially bleeding, is protective. We don't remove inflamed tissues or any other tissues. We remove the tooth surface irritants. Ramford says that most of the pathogenic organisms live on the tooth surface and in the crevice or the pocket, but some may also be present within the tissues of the pocket wall. However, there's ample evidence that the elimination of surface organisms without any specific antimicrobial therapy will lead to the healing of the periodontal lesion. We have the same idea in our practice. We do not subject our patients to antimicrobial therapy. We eliminate the organisms from the roots, and the gums will do just fine on their own. Ramford found that periodontal pockets from 4 to 12 millimeters will, on average, respond favorably to periodontal therapy. The prognosis is as good for deep as for shallow pockets, provided the teeth have adequate support for function. The reason here is critical for our practice and our philosophy. We have carried the ideas beyond this 1989 text. The periodontal probe is useless for prognosis. Measuring the so-called pocket with a millimeter depth gauge gives no information about disease activity at all, no cellular, molecular, or chemical information. Ranford noted that while some therapists can meticulously root plane the teeth despite deep pockets, it needs to be emphasized that root planing is one of the most demanding disciplines in dentistry. Root planing is a term borrowed from carpentry, and it means scraping a surface until it's completely smooth and hard. That's called planing. Basically, returning a tooth surface to a biologic acceptable form can be technically difficult. It takes knowledge, commitment, and experience to do this well. Ranford noted that in the past, the main objectives of periodontal surgery were to eliminate pockets deeper than 3 millimeters and to provide optimal contour of the alveolar process and the gingiva. These two objectives have proven to be of no value for the future maintenance of the teeth in health and normal function. Surgical pocket elimination is not essential for a good prognosis, does not have a favorable effect on the maintenance of attachment for the teeth. So there's the scientific support for our type of treatment. Once again, all of the teeth lost because of periodontal reasons in Ranford's studies had residual old calculus or inaccessible furcations. Both professional and personal oral hygiene proved inadequate to stop the progress of periodontitis when residual infection was left on the root surfaces. The common cause of loss of teeth after treatment is residual calculus and plaque associated with furcations. In other words, it begins and it ends with a clean tooth surface.